Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 2 of the basic dermatology curriculum organized by the Saudi Society of Dermatology and Dermatologic Surgery. Thank you for joining us today. So this session is being recorded and will be made publicly available along the course content on the Society's official platforms on social media after the course completion. So today's session plan will include the main lecture delivered by Dr. Abdullah Aman, followed by a 5-minute scientific talk by L'Oreal. So please feel free to type your questions in the chat at any time, and we will address all the questions during the Q&A segment at the end of the session. So our session today will be delivered by Dr. Abdullah Aman. He is a board-certified dermatologist and pediatric dermatology fellow at Sick Kids Hospital in Toronto, and a dermatologist at King Abdulaziz Medical City in Jeddah. So thank you very much, Dr. Abdullah, for joining us today. It's a pleasure and honor to have you with us.
Assalamu alaikum. Thank you for giving me this opportunity. So today we're going to talk about the cutaneous viral and fungal infections, clinical recognition and management. Our goal today is just to address the common viral and fungal infections affecting the skin and discuss the key clinical feature, distinguishing feature between them. Whenever there is a treatment, we'll also discuss the possible treatment, and also we'll focus on the prevention in terms of, for example, vaccination and screening if it's possible. And we'll touch base only on the important aspect of these infections. So first, we start with a viral exanthem. We hear a lot about viral exanthem. So an exanthem means as a widespread rash that could be macular or papular, usually referred to those occurring in children. Historically, there has been numerical names for these viral exanthem based on their discovery. So we usually hear about the 5th disease, 6th disease. So that's basically the order that by which they have been discovered. So, for example, first disease is the measles, and then second disease is the scarlet fever, which is a bacterial disease, and so on. And third disease is rubella, fifth disease is erythema infectiosum, and sixth disease is roseola, which we are going to talk about all of them. Fourth disease is most likely was just misnomered as like a viral exanthem, and it was just a mild virus that had some kind of rash. So first, we're going to look at these photos. So here we can see the description that when we say an exanthem, that's what we mean. Basically, an erythematous, macular, some papular rash over the body. And here in this patient, we can see that it's coalescing into a larger islands of erythema, also including the face. We can see the enanthem. Enanthem means the rash in the mucosa. Here we can see that we have a grayish maculas that's surrounded by erythema. So this is, as you know, this is measles. We just talk a little bit about measles. So measles is caused by measles virus. It's transmitted by droplets. Why measles is important? Because it's very highly contagious. So secondary attack rate is 90%. So if someone is infected and there are 10 in the room, 9 of them will get the infection. That's the first important thing about measles. Second thing that we are going to talk about later, that the infection complication. That's why this infection is very important. So how does it start? It starts with prodrome. Prodrome lasts for around 3 to 4 days. Fever and the 3 C's, cough, coryza, conjunctivitis. And then at the same time, they have the Koplik spot, which later disappear by the appearance of the exanthem, the rash. So when the patient rash, most likely he will not have the Koplik spot. The rash usually is cephalocaudal, so it goes from head to toes over 2 to 4 days, and then of the 5th day, it will disappear. It's important to know the description of the rash just to know how to distinguish them, because if you see them clinically, most of them will look similar. Maybe measles will have this larger plaque, but the goal to just recognize the infection. I know that's, for example, important. So if you see someone with a high fever, conjunctivitis, and this rash, you should think about it, because even though we have the vaccination, there are still people who don't get the vaccine and get the infection. So as we said, the second most important thing is the complication, high rate of complication, 40%. The most important complication is the respiratory tract infection, bacterial infection, pneumonia. And some people have the risk of developing the subacute sclerosing panencephalitis, which occurs many years after the infection, with like seizures, coma, death. Diagnosis, the gold standard nowadays is the PCR. Serology is still available, but PCR can rapid and can diagnose it. Treatment for the measles, we don't have like one treatment, it's just supportive care. However, prevention is the key. So the vaccination, as we know, there are 2 doses, MMR vaccine. One thing that can be unrecommended for treatment is the vitamin A supplementation, and the goal is to prevent the ophthalmic complication, because people who are low in vitamin A, when they get this infection, they have higher risk of developing ophthalmic complication. So that's how you prevent it. Okay, second rash, as we can tell, it's similar, but however, it's not coalescing into making these larger plaques. It's milder. Here we can see some lymph node, suboccipital lymph node. So this is very characteristic and in rubella. So rubella or German measles or 3-day measles is caused by rubella virus, again transmitted by the same mean respiratory droplet. Why is it called 3-day measles? Because it's similar to measles, but it's milder. So the whole length of this viral infection usually lasts for 3 days. Okay, why rubella is important? Important because it is risky for pregnant women and can cause congenital complication. The incubation, usually 2 to 3 weeks. After that, the same thing. They will have prodrome. Prodrome usually will be milder fever, may have conjunctivitis, but not always. And then after that, they have the exanthem, which is again morbilliform rash that starts from head cephalocaudal, but it fades within 3 days. So that's another difference. And they have generalized lymphadenopathy, especially in the head and neck area. So that's why I showed you the picture of that. Complication, the main concern and complication is the congenital rubella syndrome, which if a mother gets infected within the first 12 weeks, there is a high risk, around 85%. Classical feature for this infection is blueberry muffin. We'll talk about that later. What is it exactly when we come to the most common cause of it? But there is a triad that's well known for rubella, cataract, sensorineural deafness, and cardiac defects. Diagnosis, again, PCR. There is no treatment. You can consider administering the immunoglobulin in pregnant women. One thing that's very important, that sometimes in older individuals, this infection could present with mild disease and severe arthralgia, usually in female. Okay. This is the third exanthem. Again, it's similar. However, the scenario is different. So in this patient, he developed prodrome of fever for a few days. And then after the fever subsided, he started to develop this rash over the face, which then also subsided or started to get better. And then he developed this maculopapular. It's coined as reticular lacy erythematous macules and papules over the extremities. So this is basically erythema infecciosa, fifth disease. It's caused by parvovirus, B19, transmitted again by respiratory secretion, but also by blood and placenta. And that's very important because we'll come again to the pregnant woman topic. Okay, so as we said, they have the prodrome. After the prodrome of the fever and myalgia and headache, they develop the exanthem, which start as slap cheek. At this time, they are not contagious, and that's very important. So they are contagious just in the fever stage. After that, this slap cheek rash lasts for a few days, and then they develop this maculopapular lacy reticulated pattern that we saw on the extremity that may last for a few weeks. Okay, not all the individual will get the slap cheek, but that's the classical thing about it. And older individual, they may not have the full disease, and again, they will just have arthritis, especially in the female. This infection is very high risk in probably two population. One is the pregnant woman, as we said, because if the pregnant woman get the disease, it would be passed through the placenta to the fetus, and then in the fetus, it can affect the blood cells and cause fetal death because it has a receptor for RBC's precursors. And the second thing, if a patient gets it and he has hemoglobinopathies like sickle cell disease or thalassemia, again, they can get aplastic crisis and pancytopenia. Okay, so this is another rash again. This one is a bit different. As we can see here, this patient has some kind of, let's say, petechial macules over the palms, dorsal hands, and even the sole. Sometimes it's accompanied by very painful or pain, so they cannot walk, so they will need a wheelchair like this patient. So this is popular purpuric glove and sock syndrome, usually in young adult. It has symmetrical edema and erythema of the palm and sole. And this is highly infectious even when they have the rash, not like the slap cheek. Usually it will disappear by itself, and diagnosis again by PCR, you can diagnose. You can use serology if you want. But it's very important to know, just to know, because it has a unique presentation and it's very painful for the patient. Here another rash that we can see, again, it's the same scenario. Same, probably if you look at it, you will tell it's like probably same presentation. However, here again, the scenario is different. So in these kind of patients, usually younger individual from 6 months to 3 years, they developed high fever for a few days, 3 to 4 or 5 days. And then after the fever, they develop this rash. Sometimes they will have periorbital edema, like here. You can probably see it, or maybe some enanthem inside the mouth. So this is roseola infantum, is the 6th disease. So in this page, in this, this is one of the, usually, as we said, in 6 months to 3 years. This is caused by herpes virus. And human herpes virus, as we were going to see, it has 3 phases: primary infection, latency, and reactivation. Just like the herpes virus that we all know. This virus can come as this roseola infantum, and later it can reactivate. But if it will get reactivated, it will not reactivate as roseola infantum, but it can come with like other associated diseases, like, for example, stress or something like that. It can be associated with it. Not all individuals will have the disease, so a lot of patients are subclinical. The characteristic presentation is very high fever for 3 to 5 days. With this high fever, because they are young, they can have the febrile seizure. After that, the resolution will have this pink rose macules and papules. They can have the edema over the eyelid, as we saw in the photo, and then, they can have the nigama spots, which are red papules and the soft palate. What's very characteristic is the high fever that subsides, and then they develop the rash at the younger age. This is again another like exanthem, probably similar to appearance. What's very characteristic here is that it affects only one side of the body, and then later it might spread. This is called unilateral laterothoracic exanthem. It's very benign and mild. Just to know that It exists, it comes in this side, and then it may generalize, usually lasts for a few weeks, and then it goes away. One of the important differential diagnoses, because it can present as an eczematous rash, is contact dermatitis. Here another rash that we can see. What's very important about this rash is if you can tell if the lesion is edematous, papules, and plaque. Some of it has like some kind of pseudovesicular or vesiculopapular appearance. It involves usually the face, the knees, the buttock, and the elbows. Usually it's spared. The trunk is, you can see the trunk is very spared. So that's very characteristic for this rash, which is like gynotic crusty syndrome or papular acrodermatitis of childhood. Historically, it's been associated with hepatitis B, but EBV nowadays is the most common reported agent. It's very, again, benign. However, because it stays for a very long time, usually up to 6 weeks or even longer, so a lot of people will come for consultation regarding that. It may be itchy or not, but that's it basically. So it's just important to recognize and know it. Here another very important rash that we can see. So these people usually present with this typical oval-shaped vesicles, as you can see, usually involving the hands and the feet and the mouth. So here we're talking about the enteroviral infection. Enterovirus is a group of a lot of viruses like polio, Coxsackie, echo, and other viruses. In dermatology, maybe there are like two important diseases that we think about: hand, foot, mouth disease and herpes. Hand, foot, mouth disease is a very common disease in childhood. Usually it comes in seasons. Most common cause is A16 and A10. And that's what usually causes the classical HFMD, but there is also recently association with A6 and E71. We'll talk about this one because it's very important. Transmission, like enterovirus, usually is fecal oral or contact with the lesion. Incubation usually a few days, and then it starts the symptoms with the mouth. So sore throat, dysphagia, because they have the lesion in the mouth that later get to ulceration. After that, or during the same time, they may start to develop a rash over the hands and feet, usually involved dorsal hand and the palm of plantar. Okay. What is very characteristic for the vesicle is the oval shaped, as we can see here and here and here. Okay. CVA16 or the Coxsackie 6 is very important because it has been associated with outbreaks of generalized hand, foot, and mouth disease. So it will not present with the classical pattern, and it can present with generalized vesiculation and sometimes even bullous lesion. So that's why it's like important. The enterovirus 71 associated with neurological cardiopulmonary complication. One thing also of the complication that is associated with Coxsackie, it can actually infect eczematous skin and cause eczema coxsaccicum, which will appear as punch out ulcers over or widespread over the body. So this is the bullous disease that can come with the Coxsackie A6. Okay, so again, no need to treat. It's just need to be aware of this infection and the risk of it being contagious to others. Usually after the infection, few months, the patient may come with this thing, which is onychomediasis. Basically, because this virus affects the nail matrix, it can lead to matrix arrest and then separation of the nail bit, or cutting like this. Onychomediasis. Herpangina is similar to hand foot, but only affecting the mouth. Okay, and there is no exanthem usually. So here, this is a very important rash. Again, probably it's a similar rash that to the one that we saw. Usually it would appear with this kind of rash. It can have actually polymorphous rash. But here we can see exanthem. With this example, exanthem, cracked lips, strawberry tongue, conjunctivitis, lymph node, and then distal extremities changes, edema, and swelling. So this is a very important disease, which is not viral, but I had to put it. So it's acute febrile mucocutaneous lymph node syndrome, Kawasaki disease. Usually affect people who are less than 5 years, but it can affect actually even adolescents. So we've seen it in people who are older. Unclear etiology, but could be viral. Most important complication to be aware of is the coronary artery aneurysm and vasculitis, so it can lead to mortality. So the incidence of the cardiac complication is around 25% without the treatment, and the mortality is 2% without the treatment. If they use the treatment, the incident will be 5 to 10%, and the mortality will be around 0.2 to 0.3, so less by almost 10 times. So how does it present? Usually, because we don't have a diagnosis or viral etiology, so the diagnosis is based on criteria. The criteria is 5 days fever plus 4 of the following. Maculopapular rash. What's very characteristic for this maculopapular or polymorphous skin rash, that it starts in the perineal region. So sometimes it will start here, and then it will be the first site for desquamation. So this is the first criteria. Second thing is the cervical lymph node, conjunctivitis, oral changes, could be cracked lips, strawberry tongue. And then we have the swelling and erythema of palm and so on. So if you have 4 out of 5, then you have the diagnosis, you can start the treatment. If you don't have 4, then we go to the atypical form. So that's this picture just to show you that sometimes how it starts actually in this area and sparing the other area, and later will just go away. And then how it desquamate. So sometimes you can use laboratory testing to assess, like increase in CRP, ESR, CBC, changes, decrease albumin, increase LFTs, and also like refer to cardiology, very important. These are important because when you talk about the atypical, that's what we are going to use. So if you have a patient who has 2 or 3 criteria and does not fulfill the criteria of Kawasaki, what you can do is check these acute phase reactants, CRP and ESR. If they are elevated, you can do the echocardiograph, and if it's positive, you can start the treatment. If not, you can check the supplementary laboratory criteria, which is hypoalbuminemia, anemia, elevated alanine aminotransferase, neutrophilia, thrombocytosis, and also urine test for sterile pyuria. So you need to do both. And then if you have 3, you can start treatment. The second scenario, usually an infant who are like less than 6 months of age, because these people rarely present with the completed criteria and have high risk of actually coronary artery disease. So anyone who has the fever for more than 7 days, they should do echocardiograph, and if they have the elevated ESR and CRP level also. So these are the 2 important scenarios, and start treatment, of course. So the treatment is probably very long, but in short is high dose aspirin until the fever subsides for a few days, and then you lower the dose, and then IVIG. And then again, you can repeat the IVIG. There are some cases that are resistant to treatment, but yeah, but there are a lot of treatment that can be used. But for our talk today, that's the most important thing: aspirin, IVIG. Even though there are a lot of talks about aspirin, but IVIG is the cornerstone. So this is photo just to show you the difference in some rashes that can appear in the mouth and the face. So here, Kawasaki, we can see here the cracked lips, the strawberry tongue. In staphylococcal sclerotic skin syndrome, which will be probably discussed in the bacterial chapter, they have this radial fissuring with desquamation, scaly desquamation, very because the bacteria toxin only affect the superficial layer, so they have this like very superficial scaling. So that's very important to recognize, because if you see it, then the patient is at high risk. And then erythema multiforme or Stevens-Johnson, where they have the bloody crust over the lips. These are the most important in terms of like beads. Here we go to another types of viruses. Again, in this rash, we can see different morphology, flat skin color, papules over the face, over the dorsal hand. Here, again, this is like different morphology, subangual hyperkeratotic lesions, black dots, filiform lesions. So this is wart. So very important thing about the wart is that we have a lot of genotypes to cause this virus, which can affect the skin and mucosa. The morphology depends on the type, location, and so as we saw in the picture, it has different presentation, risk of malignant transformation in some, especially the genital ones, because they carry risk of having the high risk groups, which we are going to talk about. But basically, we talk about first the non-genital wart transmitted via person-to-person contact or contaminated surfaces, or walking, for example, without shoes, barefoot. So these are the risks. Most of the cases, or let's say third of the case, more than third of the cases resolve within few years by its own. But if you see a lot of warts and progressing, you should think about immunosuppression. This is the common wart, the verruca vulgaris. Affect any site, but usually affect the fingers, dorsal hand, and it usually presents with hyperkeratotic, exophytic, dome-shaped papules like this. Plantar wart usually present exophytic or endophytic lesion. Sometimes you can see the black dots, which is basically thrombosed blood vessels. And here, in this case, for example, this is endophytic growth. So what you can see is actually partial. It's just only a part of the virus growth because it's growing inside, and usually it's causing severe pain in this situation. It's called Myrmecia wart. So just different names for just different presentation. Here, the flat wart, which is sometimes difficult to diagnose because it doesn't have the classical shape, similar to the wart, different genotype, but the same presentation, same treatment. Same treatment, different presentation. Usually, the wart like to infect the area that has abrasion or trauma because it has to go to the basal layer, and from the basal layer, it starts the infection. And by changing the gene expression, it can lead to excessive proliferation and the formation of the hyperkeratotic skin, and also excessive blood vessel formation, and that's why you see also the thrombosed blood vessels. Treatment, it depends if it's like single or multiple, if the patient would like to be treated at home or in the doctor office. So if you have few lesions in the doctor office, what they can offer is cryotherapy. Surgical removal is also an option. Cantridin, which is a topical applicant that can lead to blister formation, can also be used. If the patient wants to use something at home, usually we combine with the cryotherapy is the salicylic acid preparation with other method like a Micomod. If it's recalcitrant and multiple and not being not responding to treatment, we can try the immunotherapy with skin test antigen like Candida, PPD, or even the HPV vaccine. Genital wart, very important because these are the most common STIs, the sexual transmitted infection. Maybe subclinical, so you don't see it, but it can be contagious, caused by HPV 6 and 11. These are, when you have these, that indicate that you have been exposed to HPV most likely through sexual contact, which increase the risk for having the other high risk types like the 16, 18, 31, 33, and so on. So these by themselves, the one that cause the genital wart, are not like the precancerous, but they can actually indicate that you have been exposed to, or the patient has been exposed to the high-risk viruses. Because these high-risk viruses have risk, for example, for the cervical cancer. And we have prevention, which is the prophylactic HPV vaccine. When it's in the cervix and these high risk, usually it presents with this flat wart, condylomata plana. When it's in the low risk, usually presented the genital area, sessile smooth surface, papillomatous, skin color to brown lesion. Some variant are actually precancerous, like pyonoid papillosis, but the typical one are not. But they have, that means this patient has increased risk of the high risk ones and can transmit them, because these can turn into cervical cancer. Nowadays, we have a vaccine cover up to 9 of these high risk HPV types and can be given from age probably 9, depends on the country, but from 9 to 45. Treatment similar to the common wart, but here we use usually in the patient, we use imiquimod, not the salicylic acid. We use, so maybe you can consider polyfolate toxin. In the office, cryotherapy can be used, or surgical excision. Chemical peel agent like trichloroacetic acid. So like either destruction or removal, that's how we do it. There is no specific antiviral agent. The best is just prevention of the cancer by the vaccine. Here we shift gear into another type of viruses, which is, I think, very well known, the human herpes virus. We'll come back to this photo, but human herpes viruses, total of 8. We've already discussed type 6 and 7. And they share infection, latency, and reactivation. What's very important in the human herpes type 1 and 2, type 1 usually causes the orolabial, genital usually type 2, but they are interchangeable. The latency, if the virus is causing orolabial, will be in the trigeminal ganglia and here sacral ganglia, and then with reactivation, they will come through the nerve to specific area. Usually the primary infection is asymptomatic most of the time, so either orolabial or genital, but if they present, they're usually more severe than the reactivation infection. So in the pediatric, they will have gingivostomatitis, severe, like I'll show you here, for example, going inside, and in the reactivation, they will come as the cold sore that everyone knows. In the older individual, it may present with throat pain and dysphagia and mononucleosis-like syndrome. And then the reactivation will come again like cold sore. Genital, again, most of it will be asymptomatic, but it can present with very painful lesions in the genital area. And then reactivation can be subclinical, so they can still infect others without a lot of vesicles, or will just have limited number of vesicles. Very important thing in this type of viruses is reactivation. If the patient gets immunocompromised, the reactivation will be very severe. Okay, human herpes virus also is responsible for one, especially is responsible, and sometimes two, responsible for other types of infection. One thing is very important is this one, eczema herpeticum. So people or children who have eczema and suddenly develop high fever, and you look closely, you see these punch out ulcer that coalescing together. You should think about eczema herpeticum, because most of these people will need to be admitted to hospital. Sometimes it can present with just finger infection. So this is herpetic with a very important differential diagnosis to the acute paronychia, which is bacterial. So this is not bacterial. And then herpes gladiatorum, usually irregulars, it will appear in this skin contact area. So for example, axilla. And if it presents with very severe presentation like here, we think about immune deficiency. So this is, as we said, eczema herbaticum. Usually it infects when you have eczema or other skin disease that have skin barrier defect, like for example, diarrhea disease. Herpetic whitlow, we talked about it, gladiatorum and immunocompromised. Also, herpes simplex virus is responsible for other type of infection like encephalitis, very severe keratitis, like the eye infection, and also it can cause infection in the newborn, like ulcerations or congenital. Treatment, it depends on the patient's situation, but antiviral like acyclovir can be used IV if the patient is in like severe infection or immunocompromised or a neonatal HSV or someone like eczema herbaticum, or it can be oral. Topical can be used for cold sore, but it's debatable. And we have suppressive daily dose for patients who develop cold sore more than 6 times a year. They can use it like on daily basis all year long without stopping with the low dose. This is another type of reaction. It comes like 3 zones, as we can see here. Usually after a few weeks after the herpes virus infection. And so it's triggered and associated with it. The HSV, it is erythema multiforme, okay? Here we go to another virus. Again, here the presentation is a bit different. We can see here a lot of vesicles, but what's very important here is you can see vesicles and crust and sometimes just like papules, so different type of lesion at the same time, sometimes oral lesion. And if it reactivates, it will come with zoster. So this is varicella zoster virus infection. Primary infection is varicella, which is the chicken pox. The infection usually is airborne and droplets. Airborne, so it will stay in the air, and sometimes you need the N95 for that because it's highly contagious. It starts with fever, malaise, prodrome feature, and then they start to develop pruritic macules and papules that develop into stages: vesicles, pustules, crustation, and then healing. What's very important for this like scenario that they keep getting new lesion for around 4 days. After that, they don't. And by the 7th to 10th day, everything will be just crusted. And when you see the crustation, that means the patient is not contagious anymore. But if the patient keep presenting with more like new lesion beyond the 4th day, that means the patient maybe is immunodeficient. Okay. Very important thing to recognize that lesion is in all stage of development. It can affect the scalp, face, and then spread caudally, sometimes mucosa. Even people who have the vaccine before, they can have breakthrough varicella, or patients who have like got the varicella before. Most important complication, and that's what we really care about, is the secondary bacterial infection. So you have to check for that. And then less common, they can develop other system which can be fatal, like pneumonia, CNS, and hepatitis. Okay. Reactivation, as we all know, zoster comes localized in one dermatome. Most common would be in the trunk because it will the latency will be in the thoracic vertebra ganglia, dorsal root ganglia, and then will just get reactivated. In some people who are immunodeficient, you may have also widespread zoster. So that's very important. The most important complication for this virus is the post-herpetic neuralgia, which can appear in 10 to 15%. Why? A very important thing for this virus is now we have vaccine that can prevent the varicella infection, or at least like make it mild. And then we have the zoster vaccine, which also very important in decreasing the risk of having severe zoster infection, and it actually can decrease the risk of the post-herpetic neuralgia if the patient has like or developed the virus. This is another virus, again, similar rash to whatever we've seen before, some macular rash. And then we have another presentation for this virus, which is the genital ulcer. This virus usually or classically does not present with rash, but I just put so we know it. This is the EBV, which is considered one of the human herpes viruses. Usually present with infectious mononucleosis, which we all know present with like fever, lymphadenopathy, and then pharyngitis. And they have the risk of having hepatosplenomegaly. That's why they have to avoid playing contact sport. In certain people, around 10%, they can have faint erythema. But what's very important about this infection is that if they develop, if they by mistake were given penicillin, they can develop antibiotic-induced rash that we've just seen in around 100% of the patient. And it's not a true allergy, it's just a reaction. Okay. So that's why I just put this rash. Less often, it can present with gynotic crusty, the one that we've seen previously, and then the genital ulcer had this one, which is called Lipschutz ulcer. Sometimes it's just mistaken for human herpes virus. Usually in young girls can be seen. Okay, reactivation of this virus usually as a lymphoma. Here we're talking. This is the blueberry muffin baby that we saw in rubella. So this is a picture. It's usually presented with solid violet, purple colored nodules and papules and plaques at birth. What they actually represent is a site of hematopoiesis, which means synthesis of blood cell. So what happens usually during the embryology period, what's responsible for making the blood cells is yolk sac, then the liver, then the bone marrow. So if there is, and during this like initial period, the dermis is responsible for a small amount of this synthesis. So if the bone marrow is non-functional, or there is infection, or there is another cause that has like damaged this bone marrow, these poor infants can continue to have the hematopoiesis within the skin, and can have it even more. So they will develop these lesions. So if you take a biopsy, you will see immature blood cells in this, just because they are synthesizing. What can cause this is usually infection, or another thing that can cause it is a neoplasm, which we are going to see. So the most common cause for this is CMV virus, okay? So CMV virus, if you get like CMV virus as an adult, usually it's asymptomatic. Most people, 90% are subclinical. Occasionally, people can have milder mononucleosis-like syndrome. But what's important for this virus is probably three scenarios. One is congenital. So if the mother gets primary infection, there is 40%, especially in the early period, 40% of fetus getting the infection, and 10% can become symptomatic with thrombocytopenia, chorioretinitis, and the blueberry muffin lesion, and 10 to 15% can born asymptomatic and later develop the symptoms. And then the AIDS patient and the organ transplant, so immunodeficient patient, but they don't have skin things. So just to know about this virus for sake of completeness. So these are the causes of blueberry muffin. As we can see, the most important thing is the congenital torch infections, but also neoplastic infiltration. So just to know what is the cause. So it's basically extramedullary hematopoiesis, and that's like the most important cause. And the last virus of human herpes virus is this one. As we can see, again, purple to red erythematous papules. It starts actually with macula, patch stage, then can become plaque, and then sometimes can cause nodules, can affect the mucosa. So this is Kaposi sarcoma. It's caused by human virus 8. Primary infection is not well recognized. Sometimes it's asymptomatic, sometimes morbilliform rash, so it's not well known how it actually presents. But what's very well known, the reactivation. Reactivation can present with Kaposi. We all know that Kaposi is associated with AIDS, and it's one of the defining feature. However, there are a lot of types of Kaposi. Classic, which usually present in the lower limb, and usually elderly individual, African, usually young children, and can spread actually lymph node, bone, and skin, very aggressive, and also can be just like in the AIDS because of immune deficiency in people who receive immunosuppressant therapy, organ transplant patient. So there are a lot of causes of Kaposi. Okay. Another virus, last virus, is molluscum contagiosum infection. We all know that, but why I put, because it's very important to recognize this. It's like papule with central implication. It can present in school-age children or in adult, and probably genital area. Usually it's associated with sexual transmitted infection. Very important to know that contact with the lesion is the main cause of the infection, but also contact, for example, with other things that could have the virus, or possibly via water. Swimming pool is a very big thing about the molluscum, because there are a lot of recommendation what to do and what not to do if your kid has molluscum. But basically what they recommend nowadays is just to cover the lesion and complete swimming. Treatment, most of it will just subside by its own. However, there is risk of auto-inoculation, as we can see here. So can get from side to another side, so it could be bothersome. Cryotherapy can be used. Extraction can be used, but it's very painful. Nowadays, we have two approved medication, cantridin and perzimergel, which is nitric oxide releasing agent. These are the only two approved medication or topical medication for molluscum. These are from the CDC regarding the virus, the molluscum. They recommend covering the lesion and just swimming, because it's been like a lot of talk regarding molluscum and swimming, because a lot of people just think that one of the causes that can promote molluscum infection is actually swimming in public pool. Okay, we finished now the viruses. We'll touch base on the fungal infection. Will be quick. So just the basic about the fungus. Fungus can be divided into the biology of fungus. We can call the unicellular fungus as yeast, the multicellular filamentous fungus as mold. There are other types, for example, like dimorphic fungi, which can have both. But for our talk today, the most important thing is just to know that we have yeast and mold. Yeast is very important to know because sometimes they don't respond to treatment with typical terpenophen, for example, usually does not work with the yeast. And the most important yeast that we have is Candida and Malassezia. Okay, mold would be dermatophyte, for example. So how we diagnose the fungus? Usually with scraping. What you do with scraping is just take scale by a blade and then put KOH preparation on that. KOH will dissolve the skin and keratinized tissue, and then you can visualize the hyphae of the fungus. Also, biopsy and culture can be done. Fungal infection can be divided into deep, subcutaneous, superficial. For our talk today, we'll just focus on the superficial. Superficial means that it will just affect the epidermal layer of the skin. We can divide it into non-inflammatory, like tinea versicolor, and inflammatory, which are the dermatophyte infection. Okay, so this is what we just talked about, how to get the sample. So the first one is tinea nigra. Tinea nigra is our black hand. It presents with a patch, pigmented patch over the palm. Scaly sometimes. No predisposing factors, but it can be found in soil, shower, stalls, humid condition. So probably this is the risk factor. And the treatment for that is using topical antifungal and keratolytic agent that can just take off the skin, like for example, salicylic acid, in addition to the topical creams. This is a very common infection that we see because it's common in high humidity areas and tropical climate, usually in adolescent and young adults. It's tinea versicolor or pityriasis versicolor, caused by malassezia, which is a yeast. Usually in the seborrheic distribution, can be hypopigmented or hyperpigmented, depending on the patient. And risk factor, as we said, humidity, excessive sweating. How we diagnose? We can diagnose by, of course, clinical. Very important clue in clinical, if you actually do this thing to the rash, you will induce the scale. Just stretching the skin, you can induce the scale and see it, or you can do Wood's light and you can see the light yellow fluorescent. One thing that I wanted to mention, that sometimes it can cause, like this picture, the hypopigmentation, pigmentation, and the reason is that this fungus produce dicarboxylic acid, which is azelaic acid that we use as topical for hypopigmentation, for hyperpigmentation, to do hypopigmentation. So that's how that's the mechanism. Treatment, you can use topical antifungal shampoo, you can use topical antifungal creams and oral antifungal. Just remember that we don't use terpenophen because it's yeast. So we'll just be using mostly the azole group. And recurrence is common because, as we said, the risk factor, if this yeast is actually part of the skin flora, and with humidity, it will proliferate more and more and increase and cause the infection. Pedra is another superficial infection, fungal, very hard to diagnose, but basically this fungus infect the hair and start to cause concretion along the hair. Very often misdiagnosed with, for example, typical hair cast, or which is normal finding sometimes, or lice. But what's very unique about it is you need to this concretion, and then with microscope you can see the fungus. Okay. The treatment for that is very difficult. Most likely you will need hair shaving and cutting, and then probably using also antifungal. This is different type of hair shaft that you can see. These are the Pedra. We have black and white, but that's how they look. The net for the lice. This is a bacterial infection, a trichomycosis, and this is the typical normal hair cast, which is normal and it's easy removable. That's a very good clue for it. Okay, we'll get now to the most important part of the fungal infection, dermatophyte infection. So dermatophyte is a group of superficial or fungi that infect the superficial layer of the skin. There are more than 40 species among 3 genera: Trichophyton, Microsporum, Epidermophyton. Most important one is the Trichophyton rubrum, cause of most of the infection, but other also can cause infection. It can be transmitted human to human. It's called anthropophilic, and can be animal to human, zoophilic, and soil to human, geophilic. So usually the one from human to human is less or mild inflammatory. Zoophilic is the one that has intense inflammation, and geophilic is moderate. So for example, when you think about tinea capitis, sometimes it's caused by microsporum from animal, and it will be very highly inflammatory. And sometimes it's not, because it's not caused by this fungus. Depending on the location, it has different name. For example, in the scalp, it will be tinea capitis; in the body, tinea corporis; in the feet, tinea pedis, and so on. So the first one is tinea corporis. It's a dermatophyte infection of the skin and in the trunk. Usually it presents with this presentation, single or multiple annular plaque with elevated scaly border. This is the typical, and usually it's trachophytin rubrum, but sometimes it can also have severe presentation like this. And for sure, the treatment for this won't be enough to treat this. So just, because just to keep in mind. As we said, diagnosis, just like we said before, so KOH can be done, and or biopsy, a lot of things like can be done, but usually it's just clinical diagnosis. Treatment, these are the recommendations that you will find in the book, usually antifungal for 4 to 6 weeks, or systemic. You can use itraconazole, terbinafine. They say in the books it's like 1 to 2 weeks, but we know that, for example, this patient may need prolonged course of antifungal compared to this patient, for example, okay? Because there are a lot of resistance in the fungus, so sometimes we need even to double the dose of itraconazole to get the result. May need to make it instead of 200, 400, instead of 1 week. We may need to do it for like few months. So it depends, okay? Just wanted to mention that. Tinea cruris, the same like Tinea corporis, but it usually affects the inguinal region, inner aspect of upper thigh, usually spare the scrotal area. Again, it's the same, just like Tinea corporis, same treatment, but there are a lot of predisposing factors for this, which include humidity in this area. So it will be obesity and excessive perspiration, sweating. And anytime you find tinea infection in any site of the body, you have to look for tinea pedis because it could be the source of the infection in the feet. So the treatment is the same, just like we've said before, but prevention, wearing loose clothes, drying after bathing, topical powders just to make the area dry, weight reduction, and so on. So we need just also to be aware of the prevention of recurrence and the causes, not just treat. Tinea manum is infection of the hand. Again, it's caused by Tinea rubrum, can be caused by other kind also. Most of the time, we'll find this Mucasian type, which is hyperkeratotic. And a lot of time, we'll find this syndrome, which is called 2 feet, 1 hand syndrome. Usually, the hand is the dominant hand, and it's infected because the patient has tinea pedis, and then he infected his dominant hand. So as we can see here, it's 1 hand, 1 hand. So again, when you see tinea at any site of the body, look for tinea pedis, which we are going to talk about next. Another thing that we want to know from this case is that sometimes tinea just does not present with the annular scaly rash that we know. It may present like that. Erythema with scaling that extending to dorsal surface sometimes. Treatment, again, we can use topical or systemic, but and check for tinea pedis. And sometimes for this infection, you need systemic because of the hyperkeratotic layer. Tinea pedis is very important, and it's actually the most common cause of dermatophyte infection, or so most common type of dermatophyte infection. There are 4 types of tinea pedis that we can think about. The Mucasian type, which is, as we can see, erythema with scaling, or the interdigital form, which is the most common, and it's actually a very common cause of other tinea. So you have to always check the patient interdigital space. Sometimes and rarely can also have vesicular appearance or super infected by bacteria and develop ulcerative appearance. But these are the 2 most common types, okay? This is the most common and second most common. Treatment, again, you can try topical, but you need to make sure this, for example, intradigital form, keep the area dry, wearing socks that, for example, has separated toes. So to make the area dry, especially in people who have a very narrow interdigital space, because this could be persistent and annoying for the patient, especially diabetic patient. And you may need also to use systemic antifungal. Okay, so as we said, oral antifungal should be considered, and other dermatophyte often occur together with tinea pedis. Tinea barbe is just infection of tinea in the beard. Usually it's very inflammatory because it's caused by zoophilic dermatophyte. And very characteristic sign here is you actually can remove the hair easily without pain at this site. Tinea fasciae, again, tinea infection usually over the face. You will see the annular pattern. Sometimes misdiagnosed as eczema and treated with steroid. If you treat it with steroid, that's what will happen. This infection is actually still active, tinea fasciae, but does not have scaling because it turned into tinea incognito with using steroid. So this will later, after stopping the reoccur, after stopping the steroid, will recur again even worse. So that's why it's important, if you see something like that, you should, an annular, think about tinea before using steroid, because steroid, it may worsen it like this. Tinea capitis, very important thing. It's a disease most commonly affect children. In adult, it's very rare because in adult, usually they produce sebum in the scalp, and sebum is considered fungostatic for the fungi. So the time of, or the age when you will see in adult tinea capitis is in postmenopausal women, because they have changes in the hormone and then changes in the sebum secretion. So they may have developed it. And you can still see it in some adults, not like, you should not exclude it 100%, but just saying that most commonly it affected children, and 3 to 10% of infection usually in adult, most commonly postmenopausal women, and that's because of the just change or different sebum production, less in children, obviously. Causative agent, usually trichophytin and microsporum. These are the two genera that can infect actually the hair. Most common in the US is trichophytin rubrum, but worldwide it could be microsporum canis, which is zoophilic and very inflammatory. You can recognize the infection, the type of the infection, of course, if you do the culture or seeing the scaling, but like important clinical clue is that the trichophytin usually cause endotrix infection and result in black dots. So you will see black dots, whereas the microsporum usually will have ectotrix and may have a gray patch, erythematous patch, gray. Rarely, there are also rare presentation that this, because it's highly inflammatory, it can turn into something that's called Kirwin, that we can see here, boggy inflammation, probably super infected by bacteria. Here we can see the black dots. Here we can see the erythematous gray, and this is a very very rare type. It's called Favus, and it's caused by a specific fungus called Trichophytin chenolini. But this is the most important two that you should recognize. Why it's important to recognize which one is the cause? Because the treatment differs. The treatment usually for the scalp is either terbinafine or griseovolvin. These are the most important two treatments. For microsporum, griseovolvin is the treatment of choice. For trichophytin, terbinafine is good. However, if you don't have griseovolvin and you want to try to treat the microsporum, you can use terbinafine, but at this, like, if you are going to use terbinafine for these patients, you need to increase the duration or double the dose. So I just wanted to mention why it's important to know which type is the cause. Anyway, so oral therapy is required for all tinea capitis because topical will not be affected. effective. So not using topical, you can supplement or add on top topical treatment, but by itself is not a treatment. For household treatment, this is a very controversial topic because a lot of the adults are actually a carrier. They don't have the infection clinically, but they may have the fungus, so you may give topical treatment for them, and some people will actually, if there is recurrent infection in the same like children population, they will consider testing the parents and treat them accordingly. Also, the brushes, headwear used by the patient should be disinfected and discarded. And then the treatment, as we said, we have antifungal like rhizovolvin, terpanophene. These are the ones that mostly common used for the tinea capitis. Again, for microsporum, if you are gonna treat, which is the one that's usually erythematous and very inflammatory, you need to extend the course or double the dose. Okay, last thing in the dermatophyte is tinea inguinum, which is part of the onychomycosis. We all know the onychomycosis, which is the nail fungal infection, most commonly is caused by dermatophyte, accounts for 90%, and this is what we call tinea inguinum. However, 10% can be caused by non-dermatophyte. Most common cause is rubrum again, frequently associated with chronic tinea pedis. Again, we should always check for tinea pedis. Trauma, diabetes, all of these can be risk factor. And there are a lot of types. The most common type is the distal subungual type that we will see. Sometimes we will find superficial white or proximal. And these types, especially the proximal subungual, should alert physician to investigate for immunocompromised or HIV infection. So this is the typical infection, usually start from the distal or lateral, and then this is the superficial white. Treatment, usually, again, we use terbinafine for 12 weeks for toenail and fingernail involvement. If the patient cannot tolerate the weekly doses, you can consider the daily doses, you can consider weekly doses with fluconazole. If you have fingernail involvement, first of all, if you have just fingernail involvement without toenail, you should actually question the diagnosis because it could be psoriasis and not fungal infection. Because tinea usually will cause toenail and then fingernail, but fingernail without toenail, you should just question the diagnosis and look for psoriasis or other causes. But usually, if it's just finger and proved to be fungal, course will be half. So instead of 12, will be 6 weeks. Candidiasis, last thing in the fungal infection, there are a lot of types of candida infection or presentation, most commonly caused by Candida albicans, predisposing factor diabetes, xerostomia in the mouth, hyperhidrosis, HIV, systemic antibiotic, all of that can cause it. There are a lot of types of infection. First of all, candidal enterotrigo, usually pink to bright red, moist patches with satellite papules, and that we can see here. So these are the red patches, and these are the satellite papules. We can see here involvement of the scrotum, as we said before, dermatophyte usually spare, so that's a big difference. Then we have the thrush, oral thrush, as we all know, usually associated, seen in the mouth and can be associated with immunodeficiency or xerostomia. Another infection that is very classic and comes in the oral cavity is this one, median rhomboid glossitis. Also seen with candida, candidal paronychia. This is chronic paronychia. Chronic paronychia most commonly is attributed to allergic or irritant contact dermatitis, so people who have occupational exposure, and then with time they can get super infected. So when you see this, the most important thing is actually to eliminate the risk factor, which is the occupational exposure, and you may consider giving also topical steroid or topical antifungal to treat it, but just wanted to mention that. chronic paronychia can be associated with candida, but most common, like the initial cause is actually the occupational exposure, not like the acute paronychia, which is usually the bacteria. The angular cheilitis also can be caused by the fungal infection, and erosive interdigitalis plastomycetica, which is similar to the one that we saw with the intradigital tinea, but it can affect the hands like this. One, it's erosive, and it also can affect the toes, and also vulvovaginitis. Candida also has like important role in the congenital candidal infection and neonatal candidal infection. So that's another talk, but it can cause that. So as you can see, candida has a wide spectrum of infection. For example, in the neonate, it can present with pustular eruption. Last thing for today, I just wanted to add this to cover it. The parasitic infestation, we'll talk about just the scabies. So scabies is Sarcoptes scabies var hominis, that's the cause. And I just wanted to add this long name because hominis, that means it's just affecting the skin, the human. So the infection only transmitted from human to human, not from animal. So it's not from dogs, not from cats or any animal. And that's why the most important risk factor is overcrowding. And the scabies can live up to 1 week outside the human. So from usually 2-3 days up to 7 days outside the human. So if someone is infected and his, for example, clothes or anything, can live on it for a few days. And then if someone wear these clothes or touch it, he can get the infection within these 7 days. And that's how this infection is transmitted, either per personal contact or personal vomits. Classically affects the intradigital space, wrist, genital area. Usually it takes few weeks for the symptoms to appear because the symptom is itching due to the hypersensitivity to the parasite or parasite particle, or the scabies or the scabies particle, the mite or its byproduct like the feces or the eggs and so on. But if someone gets reinfected, usually they will get the infection, the symptom faster because they have been already sensitized. Some people who are immunocompromised can get a very severe infection, crusted scabies it's called, or Norwegian scabies, which will be infestation with large number, hyperkeratotic lesions, and very highly infectious. Diagnosis, usually it's clinical. The clues is pruritus in household, and then history of personal contact with someone with scabies, distribution of the lesion, and type of the lesion. So how is the symptom? Usually intense pruritus, classically accentuated at night, or with hot bathing or shower. Usually the cutaneous lesion symmetrical and affect first the interdigital web space, the flexural wrist, axilla, umbilicus, and the genital area. In the infant and elderly, face and scalp can be affected. These usually are not affected in the young or the adults or even children, but in infant they can be affected. Usually the lesion is like that. Erythematous, papules, sometimes they form these indurated nodules. This is the axilla, the trunk, the genital region, the umbilicus. So that's the typical lesion. So it's not very specific, but it's like erythematous papule with excoriation and indurated nodules. That's how they call it. Sometimes you will find this, but it's very rarely to see it. The borus of the fungus, the scabies itself. And in some infant, you can see the acropostulosis, which has been associated with scabies, not always occurring with scabies, but it can be. And encrusted scabies, that's what you will see. Very scaly crustacean, like here or here, of course, more severe than this, but this means this patient has a lot, like thousands of mites. Diagnosis, usually mineral oil. So you will apply mineral oil over the lesion, and then you will take the blade, and then take this mineral oil again, put it in a slide, and then visualize it. If you see the mite or you see the egg or the feces, this is a criteria for diagnosis. Skin biopsy can help if you actually get the mite and see it. But most commonly, the diagnosis is made clinically based on the symptoms that we've said, like pruritus in the household, classical distribution of symptoms. And if you see the pores, if you don't see the pores, still you can diagnose. The treatment usually is not easy. Basically, you will have to use the treatment twice for that classical cases. Day 1 and then day 7 or 8. After 1 week, there are 2 important medications, topical permethrin or oral ivermectin. Very important to keep in mind that to reduce the risk of reinfestation, to either get rid of your the clothing and towel, or just wash them with hot water and dry in hot temperature, or place in bags for 7 to 10 days. As we said, that they can live up to 7 days outside humans, so you have to keep these bags placed outside for longer than this period, so all might die. After the treatment, very important that the pruritus can actually persist for a few weeks, and it's called post-scabitic itch, but most people will actually improve within the first few days. This is how the mineral oil preparation look, the mite, the scapula, which is the feces, and then the eggs, and this is the biopsy. And this is the treatment, as we said. We have the permethrin. This is we have a lot of treatment, but the most important one is the permethrin and the ivermectin. Both have excellent efficacy. Permethrin is approved for more than 2 months old. Ivermectin is approved for people who are over 15 kilograms, but safety has been established for even people who are less than 15 kilograms. And again, we treat day 1 and day 8, and in certain cases, like crusted scabies, you can have a different course, just to know, we can treat every 2-3 days and so on. And that's it, basically. Thank you.